Dear chairs, dear colleagues, I'd like to thank Professor Kottis and the organizing committee for this repeated invitation to this established and prestigious meeting. And it is my pleasure to speak about a rather neglected but favorite for myself, favorite subject, which is skin and musculoskeletal disorders of diabetic neuropathy. So, beginning of skin disorders, we shall discuss neuropathic diabetic foot ulcers, hyperemia of the foot skin, dry foot skin, and gustatory sweating. Neuropathic diabetic foot ulcers are the most important entity. If you look at this picture, you see a bottleneck, because indeed, as we'll be seeing in a minute, it is a circular or semicircular in shape ulcer, which moves to the underlying tissue. It may even penetrate to the bone, and which looks like a volcano crater, or more elegantly, it looks like the neck of a bottle of wine. So an ulcer is a defect through all layers of the skin. And in this case, a young person with type 2 diabetes, very obese, and you see this semicircular, almost perfect in circular shape ulcer, which is in a high pressure area, that is to say, close to the third metatarsal head, and it penetrates to underlying tissue almost to the bone, like the bottleneck, as we've just discussed. This is a very important distinction because we see two ulcerations on the left-hand side and on the right-hand side. On the left-hand side, it is an ischemic ulcer, or if you will, a neuroischemic ulcer in diabetes. So we have ischemia. The ulcer is located in the borders of the foot. It has an irregular shape. It has a necrotic appearance. The borders are irregular. It is usually very painful. The skin is pulseless. The person has signs of peripheral arterial disease, and more frequently, it is a rather elderly person. On the right-hand side, again, an ulceration, but this is circular, surrounded by callus because of the preceding high pressure rubbing and friction. It is in a high pressure areas, that is to say, where plantar pressures are concentrated. We have very profound pulses. We even call them bounding pulses. So not absent pulses, but very strong arterial pulses. The skin is warm and maybe very dry. So we don't have peripheral arterial disease. We have evidence of neuropathy as seen in the deformities. And if you examine the person, you will find sensory loss of ankle reflexes, and so on. So on the right-hand side, a neuropathic foot ulcer with good blood flow. And this may be encountered even in a younger person. So this is a very important distinction. So as we've just seen in pictures, neuropathic foot ulcers are circular or almost circular with smooth borders. They are painless. Located in high pressure areas, they may extend to deep tissues, are surrounded by callus, and their complications include infection and osteomyelitis. Principles of therapy include offloading, surgical debridement or alternative debridement, treatment of infection if it is there, and of course other modalities. Hyperemia in the foot skin is manifested via increased local blood flow, which is attributable to impaired vasomotor reflex, which in turn is attributable to cardiovascular autonomic neuropathy. The clinician will notice red, warm, humid skin in the foot, and if he feels the pulses, he will see that they are strong arterial pulses, which are called in English bounding pulses. And as first described by the late Professor Ward many decades ago, you may even see distended veins in the foot dorsum, which are again a manifestation of impaired vasomotor reflex. Dry foot skin is very common, and you see two examples in the hind foot on the left-hand side and in the forefoot on the right-hand side. It is attributable to reduced sweat production, which in turn is attributable to reduced innervation of sweat glands, and this has been documented. It increases the risk of callus in high-pressure areas, and therapy includes urea creams, offloading, and appropriate footwear. This is a self-adhesive plaster, which changes its color if there is enough sweat in the foot. So it is a well-known and highly published marker of dry foot skin, which has been shown, as you can read in the title here, that it is also a very good screening tool of diabetic peripheral neuropathy. Gustatory sweating is very rare. It means increased sweating in the face, neck, and upper chest after eating certain foods which are hot, spicy, and tyramine containing. Again, it is attributable to dysautonomia, and therapy includes avoidance of certain foods and anticholinergics. Number 2 is musculoskeletal disorders. And we'll be discussing neuropathic ulcers, actually already referred to, deformities, Charcot osteopathy, and others. So deformities. This is a patient of ours, and you see 2 deformities, hallux valgus bilaterally, and overriding toe, that is to say the second toe is on top of the hallux. And this has 2 risks in itself. The first inherent risk is ulceration on the dorsal aspects of the overriding toe, of the second toe, if the footwear is too narrow and too low. And the second risk is ulceration on the pulp of the second toe because it is pressurized against the nail of the hallux. So deformities include claw toes, hammer toes, mallet toes, triangular foot as just seen, and others. Claw toe, left-hand side, mallet toe, right-hand side, and hammer toe, again, bottom right-hand side. Again, mallet toe, schematically and real picture, which is very rare, claw toe, which is usual, and hammer toe on the right-hand side. These lead to increased friction and high pressures. There's no pain, obviously, because of diabetic neuropathy, and there's danger of foot ulceration. And therapy includes prophylaxis with cotton, gauze, and appropriate footwear, secondary surgical correction, that is called elective surgery, that is after healing of the first foot ulcer, and even prophylactic surgery, that is correction of the deformity to avoid even the first foot ulcer. Charcot osteopathy, first described by Jean-Martin Charcot, is a painless and very rarely painful progressive destruction of bones and joints as a consequence of neuropathy. Diagnosis rests on clinical manifestations, X-rays, bone scintigraphy, and MRI. Clinical manifestations include red and hot, that is to say, a higher than 2 degrees centigrade temperature difference in the affected foot. It is localized in the joint. It is usually painless, and it is encountered in subjects with very severe neuropathy. If you take a detailed medical history, very rarely you may find a history of minor trauma, including surgery. To make matters worse, not only is pain absent, but X-rays are initially normal. So that has been the acute stage. There's also the chronic stage, in which there's improvement of inflammation leading to permanent deformities and radiographic changes. So this is the healthy foot with the pedal arch, and you see the Charcot foot with the collapsed pedal arch. This is acute Charcot. You see also distended foot, but also the distended veins on the foot dorsal. And this is a chronic stage. This patient has already lost 1 toe, and you see the classical deformity, which is called medial convexity. The other classical deformity of the chronic stage is rocker bottom deformity, as seen in a patient of ours who actually has also 2 ulcers on the 5th ray. So conservative therapy means offloading Surgical therapy, which is very rarely used, is employed in chronic stage after planning and patient selection. Conservative therapy means offloading, as seen here in this air cast as worn on the left lower extremity of this patient. Surgical procedures are minor, that is to say, ostectomy and Achilles tendon lengthening, and major, which include arthrodesis and amputation. And our other disorders are Achilles tendon shortening, which leads to pes equinus, which is the Latin word meaning horse. So the foot is like the lower extremity of a horse. Pes valgus, pes varus, pes planus, pes cavus, reduced muscle strength, and hallux rigidus. So Achilles tendon shortening is due to tendon glycation, and we come across a short and rigid tendon leading to forefoot strain, as I already said, like a horse, pes equinus, and this leads to high plantar pressures in the forefoot with obvious risk of foot ulcerations. So we need offloading and Achilles tendon lengthening, which is a very minor surgery, at least in very experienced hands, as seen here. It is thought to be a very simple and minimally invasive procedure. So, to conclude, there are important skin disorders, and these are foot ulcerations, dry skin, and others. And there are important musculoskeletal disorders, including shark osteopathy and various deformities. And all these speak to the importance of neuropathy, which has various manifestations. Some are well known and some are not. And one of the other reasons why neuropathy is very important is that we now know that it is not only a late complication of diabetes, but may occur very early, that is to say, during the first 12 months after diagnosis of diabetes, or even in pre-diabetes. And so we'll end up with this editorial, which quotes a poem by the Nobel Prize winner, William Butler Yeats, who said, talking of love, one cannot begin it too soon. And that is also relevant for neuropathy, because it is never too early to develop neuropathy if you have diabetes. Thank you very much for your kind attention.